Yep.
Okay.
Can you see my screen?
I can see your screen. I can see all our names on top. Is that on your screen?
No.
Okay.
It might be minimized.
Oh, no, that's on my screen. Hold on. Okay, give me 1 second. How do I?
Have a view at the top.
Thank you. Okay, I guess that's better. All right, go ahead.
All right. Hey everyone, I'm Grant. I'm a PGY4 over at Bayonet. Thank you, Dr. Cohen, for providing this case.
Thank you for doing it at the last minute. I appreciate it. We were having a lot of people duck out on us this time.
Oh, no problem. Okay, so we have an 87-year-old man. He doesn't have any specific visual complaints. He's got a history of a vitreous hemorrhage in the left eye that happened 2 years ago while he was on a full body vibrating machine at the gym. And then he's got type 2 diabetes without any ocular complications, AFib, hyperlipidemia, and systemic hypertension. He's on some hypertension meds, some GERD medication, statin, finasteride, Xarelto, and some supplements. His visual acuity is 20/25 OU, and pressures are 15 and 18.
Okay, so we have a color fundus photo of the right eye. Vitreous is clear. The nerve looks pretty sharp and flat. Some peripapillary atrophy of nasal or temporal pigmented crescent. Oh, sorry, I could do this too. Pretty good foveal reflex. Not seeing anything grossly abnormal.
Very
And
nice.
I don't think they can see your pointer, but you can see his pointer.
Oh, okay.
That's right. But you can point.
Okay.
I'll try to follow what you're talking about.
Okay, sounds good. Okay, so vitreous clear, nerve looks symmetric to the other side, sharp pigmented temporal crescent, attention's drawn to the large area of appears to be intraretinal hemorrhages that follow the superior arcade and stay relatively superior to the macula. Otherwise, retina appears normal. And then we have a wider field, oh, sorry. Yeah, so we have a wider field view that kind of shows the intraretinal hemorrhages extending out along the arcade and then a larger hemorrhage in the supratemporal area. Doesn't look like a ton of like any surrounding fluid though. No tears or detachment.
Very good.
So we have OCT of the right eye. No disruption of the layer of any of the layers, no fluid, good foveal contour, vitreous looks attached. Okay. This is vertical?
Yes.
Vertical, I think of also the right eye, similar appearing, good foveal contour, no fluid, no disruption of the layers.
Very good.
Okay, yeah, so OCT of the left eye. The center looks good, no fluid or disruption of the layers, but pretty still good foveal contour. But then attention's drawn to the it looks like more of the middle layers, probably the deep capillary plexus. You see some disruption of the internuclear layer that extends maybe a little bit to the outer nuclear layer, but looks to be contained in that the deep plexus.
So you're mostly, actually that area, that's all outer nuclear.
Oh, it's all outer nuclear.
And it's interesting, capillaries are not there. The outer nuclear doesn't have.
Oh, okay. I can't really see how far it's extending, but you see like a hyper reflective area in the para. Did you just call that parafoveal?
That would be.
Or is it too far out? It's like a wider image than I normally see.
That would probably be the.
Okay. Perifoveal. Okay.
I have to go back to one.
Hyper reflective area. That corresponds most likely with the area of intraretinal hemorrhages that we saw.
And then the next one should be a vertical slice.
Okay, vertical slice, left eye. Kind of similar appearing, but not as much hyperreflectivity as we were seeing before, but maybe some areas of hyperreflectivity.
You can say there's a little bit of lost
A
architecture,
little
but
bit of
not
loss of
much.
architecture, but yeah, compared to the other less so, but maybe a little bit of loss of architecture.
I mean, considering the color picture, this is pretty.
Yeah,
It's thicker. Yeah, it looks a little thicker too on top.
yeah,
But not edematous, that's like something there, not fluid,
Yeah, not bad.
not bad, yeah.
All right, doing good.
okay, so this is FA of the right eye. Right,
Infrared
That's
reflection.
IR, the nerve isn't as dark as I thought it would be, okay.
Yeah, IR is not dark.
Yeah, IR of the right eye, pretty normal appearing, looks, the nerve looks sharp and flat, I'm not seeing any large amount of hypo or hyper reflectance.
What do you think of those arteries? Are they nice and fat?
I guess the attenuation of the arteries. Yeah,
Normal for his age.
so
Actually,
similar,
normal for his age is dead.
similar attenuation of the arteries inferiorly, and then superiorly, you see areas of hyporeflectance along the areas of internal we saw earlier along the superior arcade. Okay, so this is FA, and I cannot see the timing, but it looks to be in the AV phase, or is this
Yeah.
filled already?
It's all filled.
Filled, yeah, it's like-
The right eye, so this is not the eye of interest. We
Yeah.
generally show right eye first, I don't know, you can show the eye. So typically you don't get the fill on that.
Okay, sounds good. This is a filled, of normal appearing right eye, other than, again, the attenuation of the vessels.
Yeah, it looks like this is at 136. Can you guys not see that far down on the
I
bottom?
can, but I'm really far away from it, and
Oh,
it's,
okay.
but now I can see it if I really squint.
It's okay.
Pretty young for that.
It needs refraction.
Yes.
I know, I definitely do need a
The
fraction.
upper out.
I'm
This is
like
at 5
0.2.
minutes.
Okay,
I'll try
at 5 minutes, you just see the staining of that pigmented crescent, or actually not staining. It's just the hyper or hypo, fluorescent area corresponding to that pigmented crescent.
So this is at 5 seconds.
Okay, perfect. So 5 seconds into the left eye FA, you see, all these hypofluorescent areas that correspond to the areas of pain that we saw in the front of photo along the superior arcade. So now we're in the, so now we're in the arterial phase. You see the arteries lit up, again, attenuation of the vessels, but you don't see any, hyperfluorescence of those areas of heme yet.
So it's kind of more laminar. It's like.
More laminar, okay, yeah, I guess it's starting to see the
It's
veins
starting to
as
see
well,
the
true.
laminar fill. The arterial phase is like a.
Quick,
Second.
yeah, so it's early AV phase.
And do you think there's differential filling of the vessels on the top and the bottom, the veins specifically? Yes.
Yeah, I guess it's like, it's filling more on the bottom for the, yeah, especially when you go back and forth, yeah, so. Differentially, it looks like inferior is filling more,
Yeah, superior is not quite full.
yeah, superior is not really filling as much.
Not for long, though. Now it's pretty full. Right?
Yeah, not it's full, maybe it was filling earlier inferiorly,
It is
but it
kind
still
of
looks,
alright.
it's still more so
It's
inferiorly.
later superiorly.
Yeah. Do you think there's AV nicking?
Yeah, there's nicking like inferior, here, I'll point
Yeah, on the
Here.
top, how about on the bottom?
here,
There's not too many places where they cross. This is
yeah,
It
here.
didn't sound like there was much. Same thing with the other eye. I was expecting more.
Yeah, agreed.
there's like where the yeah.
This is a wider field view that shows the areas of hypofluorescence, along that same superior arcade. You see these attenuated vessels. Is this artifact?
Yeah, it might be,
Yeah, and we're getting pretty far out, so I don't know if you would call this necessarily capillary dropout or not.
well, that's what you're looking for. You're looking for capillary dropout and neovascularization.
Okay, so I'm not seeing neovascularization, but
I
maybe,
would not call that.
but it's really far out, so usually there
Yeah.
aren't really that many out
And
there.
typically with capillary dropout, like that picture in the lecture, there's a not always,
Right.
there's usually a border.
Yeah.
Right,
So like, here it's good, here it's bad.
Yeah,
This one just
it
kind of
looks
like,
that's kind
the
of.
peripheral picture.
The reason it's a border is
Yeah.
the capillaries you see
Uh-huh.
are,
Oh,
thicker
abnormal.
than, they're abnormal, they're abnormally bright, because I think it's because they're trying to compensate,
All right.
but that's where you see it.
And we had that last year, 2 years ago, right? Somebody had a central vein
Yeah.
occlusion patient, and they decided they were talking about non-perfusion ischemia, and all they were seeing was the dark. It's pretty common for it to be dark.
Yeah, exactly. So,
The other thing is, in the areas where you have those, on the border area, the reason the vessels are probably bigger is you've had dropout of capillary layers below them or
Mhm.
above them, so you don't have your full capillary layers there. It's not, that area where you have C capillaries is not normal. It has hypocapillaries.
alright. Anything else on that one, Grant? Okay.
No, that's good.
Alright, so similar, again, this is all the areas of hypofluorescence are corresponding to the areas of heme that we saw earlier. So now that we're further along, I would call this, blocking, probably from the blood, or
Mhm.
probably blocking, right, because of the blood, yeah.
Yeah.
And so similar thing, we're just seeing it from different angles, you can see the blocking of all the black areas from heme.
All right. So
And go back one, was there any leakage in that?
I didn't see.
There's really not.
No.
It's, you have the OCT now, so you don't need it, but in the old days, we didn't have an OCT, you look for stain leakage in the center for
Yeah.
macular edema,
Yeah,
and you really don't have it.
no,
Okay,
This
go ahead.
guy was symptomatic or not symptomatic?
I think it was asymptomatic, I think somebody just saw him.
yeah,
He had no-
he had no visual complaints. I think it was like incidental and then sent to Retina for.
Send him back to the full body vibrator and tell him to have a
yeah.
flash.
I have more questions about that, what is that? What are you doing?
I don't have any answers. I have no compliant answers.
So, this is an 87-year-old male with type 2 diabetes, high blood pressure, high cholesterol, no visual symptoms. So of course, number one way differential is branch retinal vein occlusion, but he of course has a lot of risk factors for hypertensive retinopathy, like non-proliferative diabetic retinopathy, although it's really all the heme is along one specific distribution, so less likely. And then he's 87, so maybe if he has ever had cancer and radiation before, radiation retinopathy. Is there anything bigger?
No, that's good. Those are the three musketeers. You need three on a differential for the boards. Whenever you see blood, it's hypertension, diabetes, and radiation.
Right.
That's good.
So over the PGY2s, what, they always try to come with a differential first. A lot of times you know the diagnosis, but you gotta come up with a direct differential.
Yeah, I think we pretty much hit the major ones here. All right, so I think it's pretty clear this was a branch retinal vein occlusion, so I'll kind of quickly go through BRVOs. So epidemiology and risk factors. So their prevalence is 0.5 to 2%. They're the second most common retinal vasculopathy after diabetic retinopathy. And they're more common in Hispanics and Asians than in Blacks and Whites. There's no sex predilection, and 5 to 10% of them can occur bilaterally. And the most common location, like in our patient, was supratemporal. So risk factors are age, hyperlipidemia, hypertension, all these things that our patient had. Ocular hypertension is a good one. If someone has, it's one of the reasons that we treat high ocular pressure. Poor ocular perfusion, glaucoma, specifically for branch retinal vein occlusion. There's, I guess, some question about whether or not diabetes is a risk factor. I know there's an ophtho questions about this. AV nicking, which may be related to the pathophysiology, blood vessel narrowing, elevated BMI, and then hypercoagulability risk factors. Specifically, hyperhomocystinemia and anti-cardiolipin antibodies have been well studied and demonstrated to be strong risk factors. And then these other hypercoagulation risk factors don't have the strongest evidence, but theoretically would contribute to increased risk. And then
Now,
on
Grant, some of the
yeah,
stuff you're talking about is CRVO. Are you talking CRVO and BRVO or just BRVO?
this is specifically for BRVO.
Okay. I didn't think thrombophilia was such a big thing, but you found that when you were looking around?
Yeah,
Okay, all right.
yeah, I can show you the paper if you want.
All right. No, I got you.
Yeah, so just because there's an opto questions on it, and this has always confused me. This one paper I found in 2008 systematic review said diabetes was slightly more prevalent among cases with any form of RVO. The pooled odds ratio was significant. The risk of retinal vein occlusion was not significant, was not consistently higher in all studies, with opposing results in 4 studies. So it kind of goes back and forth. And then central retinal vein occlusion was significantly associated with the presence of diabetes, but BRVO was not. So that's probably where this comes from. So my conclusion is if I see this on the boards, I'm going to be not sure what the answer is.
I have to say, as someone who buys the BSC book every time they update it, in the last update, which was last year or 2 years ago, I think they might have put this to rest, and I think they said it was not a big deal. They're both a risk factor.
Yeah, I think
I just specifically mentioned, I'll try to find that. I have it online. I could probably look between stuff later. But I'm pretty sure the last BSCS book tried to sort of just get this done with.
okay. So the pathogenesis is multifactorial and not necessarily fully understood, but it's thought to be a mechanical compression of a venule by a sclerosed artery at an AV crossing. So you have this atherosclerosis makes a hard artery, which leads to venule compression and tortuosity, which causes turbulent blood flow and endothelial damage, and that leads to occlusion. That leads to your vein occlusion. And there's apparently a larger number of AV crossings supratemporally. And so that may be why there's the most common location is supratemporal for BRVOs. And then there's also thought to be some level of blood vessel wall degeneration and then hypercoagulation as factors in the pathogenesis. Loss of visual acuity in BRVO is primarily from macular edema, VEGF, and then these interleukin 6, interleukin 8, and monocyte chemoattractant protein 1 are all pro-macular edema signaling molecules. And then this was a cool thing that I found. This is some kind of like computational flow schematic showing that if you have a sudden narrowing in a pipe, after that narrowing, you have all this turbulence. And then they also kind of describe that turbulence and the roughness of the inside of the pipe is also a factor. So that kind of is associated with like endothelial damage. So it's pretty cool. They're kind of describing pipes, but they're also describing arteries and vein occlusions.
Do you find what the proportion of inflammatory cytokines is to vasogenic cytokines in retinal vein occlusion compared to, say, diabetic macular edema or macular degeneration? Did that come up?
That did not come up in my reading.
What's the answer?
The answer, there's a lot more inflammation in vein occlusions, probably because of their acuity, which is why the corticosteroids have achieved registration in vein occlusion treatment.
More than that.
Or at least first, so I said it first achieved registration in vein occlusion treatment. It's fairly inflammatory. There's pretty good data looking at the proportion of bad humors in these diseases, and the bad humors in vein occlusion tilt towards inflammation.
It's almost like MIs, like it's very
Yeah.
for that.
Similar to MIs, yeah, like the inflammation in MIs, yeah.
Yeah, interesting. Oh, no.
Okay, so diagnosis of vein occlusions is clinical, but OCT and FA are useful for further investigation. And then,
That picture is a nice non-perfusion picture.
yes, very
Yeah.
nice non-perfusion. So central retinal, sorry, go ahead.
You just notice the dilated capillaries around the non-perfused area.
Right, yeah. Okay, go ahead, Frank.
Okay, so just some classification. Retinal vein occlusions are obviously distinguished between central and branch retinal vein occlusions. And then central can be considered ischemic or non-ischemic, which most of them are non-ischemic. And the definition of an ischemic is if there's greater than 10 diameters of capillary non-perfusion, which I believe this would qualify. And then branch retinal vein occlusions, you can have a major BRVO, which is an occlusion of a vein that drains one of the four quadrants. In these larger vein occlusions, VEGF and cytokine concentrations are higher, which can contribute more so to the macular edema. And they tend to be not as good of responders to the anti-VEGF. They require more treatments and their outcomes aren't as good. You can also have a macular BRVO, which is an occlusion of a venule within the macula, or an inflammatory BRVO, which would happen with co-occurring vasculitis and intraocular inflammation. And they're typically peripheral and there's multiple of them and they're in different stages. And then if you have, for example, just like the superior hemisphere affected, you can have a hemiretinal vein occlusion as well. Signs and symptoms, so there's typically sudden painless vision loss. They can have a visual field defect that can range from a relative defect to an absolute scotoma. And floaters may be from associated vitreous hemorrhage from retinal neovascularization. And then there's a lot of different things that you can see on the fundus exam. Typically flame hemorrhages and dot hemorrhages. You can also see cotton wool spots, and you can see the edema, and then some other signs. And then
I'm just gonna throw in real quick, not to keep interrupting, but for vein occlusion, which is super duper common, so it's like really common. The main thing is everything's in one distribution. So if you're gonna look at branch vein occlusion, well, every time I see hemorrhage, I'm like, is it in one distribution? If it is, it's a vein occlusion. If you look really hard and there's other hemorrhages, then you're like, I might have a problem. It might be something else weird. But vein occlusions are so common. If you see hemorrhage, the first thing in your head, it should be vein occlusion, and the second thing should be, can I attribute this to one vein?
So also uncommonly, patients can present with neovascularization of the iris, the angle, or the posterior segment at their initial visit. Someone like this patient might have an IOP of 50 or something, and that might be their presenting scenario. And then here's some NVI. So the evaluation is a complete history and ophthalmic exam, gonioscopy, especially if the IOP is elevated, to monitor for neovascularization, OCT and FA. And then if a patient isn't optimized with their primary care, I think a workup is warranted to look for risk factors and make sure they're optimized in that sense. If patients are younger than 50, you can consider other causes like infectious, inflammatory, or hypercoagulation. Here's just a very small branch. So on OCT is nice because it's not as affected by the intraretinal hemorrhages. Like we saw all that blocking on our FA. And very nicely, you can see if there's any cystoid macular edema. And if you have some intraretinal hyperreflectivity with shadows, that can be what the hemorrhages are showing. Then you can also have, of course, subretinal fluid, like it's showing here. And then disruption of the ellipsoid zone after macular edema correlates with poor visual acuity after the photoreceptor, which corresponds to photoreceptor cell death. Fluorescein angiography will characterize the extent of non-perfusion if there's any macular ischemia, edema, or leakage. In the initial intraretinal hemorrhages may affect the image quality. And then characteristically, you'll see delayed filling, capillary non-perfusion of a varying degree, blockage again from the hemorrhages, macular edema, and then neo. So here's some nice neovascularization and capillary dropout too. So management is really to prevent and treat vision loss from macular edema, ischemia, and neovascularization. Anti-VEGF nowadays is the mainstay of treatment, but laser photocoagulation and steroids are also options. And then vitrectomy can be considered if there's non-clearing hemorrhage. So just a quick review on VEGF because it plays a major role in the macular edema from retinal vein occlusions. VEGF plays a role in normal retinal homeostasis, and it's elevated in pathologic retinal conditions. It causes migration and proliferation of retinal endothelial cells, which leads to angiogenesis. And then it also causes hyperpermeability of those endothelial cells, which could then spill plasma into the extravascular space, and that's causing your macular edema. So here's this whole pathway, a bunch of different things can be affected, but eventually VEGF leads to angiogenesis. And it's also, I guess, the anti-VEGF came from anti-cancer, so that's where this slide comes from, is oncology. So there's a lot of different.
Oh, just in the early days of VEGF, you may have, there was thought to be two factors. There was thought to be vascular permeability factor and vascular growth factor. And then it was when they were all figured and sequenced and cloned out, it turned out they're the same thing. So VEGF does permeability and growth.
It does do both. So we use anti-VEGF to treat macular edema and vein occlusions. And then sometimes focal laser can be used for durability effect. All these studies, the Bravo, Cruise, Vibrant, Balaton, and Camino trial, use this particular injection schedule. They go monthly for 6 injections and then taper. I've seen a few different ophthalmologists use different schedules than that. And then in the Horizon, they said 12 months of intensive treatment, and then they went to PRN. So generally, all these studies had very similar schedules.
Why do you think that's true?
I'm sorry?
Why do you think they have similar schedules?
Because they want to show non-inferiority to each other.
Right, they all want to register the drug. That's not how you use the drug, it's how you get the drug commercialized. Just because the FDA negotiated with Genentech for Bravo and Cruise to have the primary endpoint at 6 months. And that's kind of stuck.
That makes sense. So just a quick review on the different agents. We have bevacizumab, which is Avastin. It's a full-length antibody for VEGF. And then we have Lucentis, which is an antibody fragment that binds VEGF-A with higher affinity than Avastin. We have Eylea or aflibercept, which is a recombinant protein with VEGF receptor 1 and 2 domains fused to an Fc portion of IgG. It has the strongest affinity for VEGF-A, and then also has VEGF-B and placental growth factor affinity. And then the newest one is Vabysmo, which is faricimab, and it's a bispecific humanized IgG for VEGF-A, and then also angiopoietin-2. And then just a quick review of angiopoietin-2. Normally, there's Ang1 and Ang2, and Ang1 binds to this tyrosine kinase receptor, which promotes vascular stability. But when there's some kind of pathologic environment, angiopoietin-2 levels increase and they outcompete Ang1 at the Tie2 receptor, and that promotes all these effects that kind of also promote vascular leakage. So there's parasite dropout, endothelial cell loss, leukocyte migration, which can further induce more inflammation. And then it also leads to an enhanced effect of VEGF. And this is just like a schematic from Vabysmo's website. Very nice looking. And then another option is steroids to treat the macular edema. It can be effective, but there are significant side effects, such as cataracts and elevated IOP. Intravitreal triamcinolone is an option, which has shown to be inferior to laser after 3 years in the SCORE BRVO trial. It's generally considered to be second line or adjunct to laser and anti-VEGF. And then there's Ozurdex, the dexamethasone intravitreal implant. which was really just compared to a sham treatment, but it was shown to be efficacious in the Geneva trial. Finally, there's laser photocoagulation. It was formerly the gold standard before the advent of anti-VEGF. Basically, you destroy the capillary beds near the edema, reducing blood supply and favoring drainage of the edema. There's grid and scatter. Grid is for perfused macular edema with visual acuity of 20/40 or worse. No improvement for at least 3 months. And then FA would delineate the area of capillary non-perfusion. And then you would repeat the FA in 2 to 4 months for possible retreatment. And then scatter is to prevent vitreous heme if there's greater than 5 disc diameters of retinal non-perfusion with neo. And then prognosis. So 50 to 60% of patients with BRVOs have a final visual acuity of 20/40 or better. Chronic macular edema, a major or macular BRVO, neovascularization resulting in vitreous hemorrhage, and initial visual acuity worse than 20/50 are all poor prognostic indicators. And BRVO in one eye increases the risk of BRVO in the fellow eye 7 to 10%. There's an inflammatory BRVO with some vasculitis, retinal vasculitis. And that's it.
That was very good.
Very
Thank
good,
you.
yeah, that sounds.
Holy cow. You sent me that. That's a great presentation.
Can I